Without further ado, I'd like to introduce our moderator for tonight's session, Ms. Jennifer McKinnon from the Lung Health Foundation. Ms. McKinnon is a respiratory therapist and certified respiratory educator at the Lung Health Foundation, where she has, for the past 3 years, been leading the work in providing education and clinical services area. Thank you very much for being with us, Ms. McKinnon. You may now present our speaker.
Thank you, Claudia. And again, welcome everyone. The Lung Health Foundation is pleased to host this session along with the following 2 sessions, which bring together leading experts in the management of COPD, who will share best evidence for care and their experiences and successes along the way. We hope you will join us for the session 2 and 3, but more information about those will follow later. I have the pleasure today to introduce our speaker for session 1, Pearls for COPD Management. Dr. Durzo is an associate professor in the Department of Family and Community Medicine, Faculty of Medicine, University of Toronto, and has spent many years teaching in the department. He has been a volunteer member of the Lung Health Foundation since 1992. Dr. Durzo has had the opportunity to publish numerous articles in the area of asthma and COPD management. He has been the director of the Primary Care Lung Clinic since 1993 and is currently the chair and co-founder of the Primary Care Respiratory Alliance of Canada. His professional goal is to promote lung health in primary care. So welcome, Dr. Durzo. I will hand it off to you.
Thank you very much, Jen, and welcome everyone. As Jen indicated, there are 2 other series that will come later, so keep that in mind as we go through the session today. There's some technical points with respects to tonight's event. All lines will be muted during the presentation, and if there are any technical difficulties, there's somewhere you can call listed here. You know that the presentation will be recorded, it is accredited, and please leave comments, ask questions through the Q&A, and we will try and get through all of them. My name is Tony Durzo, and as you have already heard, I have spent a lot of time working in the area of respiratory health. These are my conflicts of interest. I've had the opportunity to work with many of our industry partners in the area of asthma and COPD care over the years. As you already know, this program has received support through an unrestricted grant from AstraZeneca. And in terms of our learning objectives, before I get into them, I do want to share a very sincere thank you to Claudia, who you've already heard, to Jen and her team at the Lung Health Foundation, and for AstraZeneca for working with all of us to put this event together. So the hope is after this evening that we will have described the clinical burden of disease and exacerbations in early COPD in Canada and help you identify and treat patients currently who are receiving suboptimal therapy, and appraise sort of the importance of using objective measures of lung function and other strategies to promote communication and knowledge during the patient and physician interaction. And finally, to recognize early identification and treatment options for COPD that can be directly applied to impact outcomes of importance and to provide value not only to patients, but to the broader healthcare system in our local communities. One of the things that most of you already know, and I'm sure you've heard a lot about it, and that is that COPD really has a center stage when it comes to the number of people affected by it. About 3 million people died in 2012 globally, and that accounts for about 6% of all deaths. It's currently the 4th leading cause of death in the world, and by 2030, about 4.5 million will die. And globally, COPD is projected to increase even more in coming decades because of continued exposure to risk factors all over the world and an aging population. So it's something that all of us are probably already seeing and something we're going to see much more of. I think if you leave tonight with any, pearl, it should be that, we can only diagnose COPD with spirometry. It is an objective measurement that can be obtained with simple spirometry. About 70% of patients with COPD in Canada are probably not diagnosed. And unfortunately, as I'll talk about later, most of them are diagnosed quite late into the disease. Typically, in the real world, COPD is diagnosed without spirometry. So people rely on the clinical exam, history of smoking, and a chest x-ray. And just a reminder that only about 20% of people in Western societies who smoke heavily will go on to develop COPD. It's only a minority of patients who go on to develop this disease. And that's really why it's important to get that objective assessment. And as you can see here, a lack of spirometry leads to a number of items that I've already discussed. But I think what's interesting, if we go to the bottom of the slide, we see that among those who have experienced any COPD symptom, only 44% have had a spirometry test done. So if you don't have access to spirometry, there are opportunities in many communities to get access, and you should find that out. A little bit more about spirometry, and that is that if patients have any symptoms that are compatible with COPD, and if they're a smoker or ex-smoker and answer yes to any one of the questions that you see here, whether they cough, whether they get frequent colds, whether they wheeze, or they get short of breath, if they answer yes, they probably should have a spirometry test done to determine if they have a disease. There are many risk factors, and I'll just share a few of them with you. Environmental tobacco smoke is probably the most common cause in developed countries. Exposure to biomass fuel is perhaps a more common cause globally. And what's interesting is that significant COPD will develop in about 15% of people who smoke. And these are people who will exhibit a very rapid decline in their lung function. And about 27% of patients with COPD are never smokers. And so many of us who evaluate patients with shortness of breath who have never smoked, typically many of them will give a history of significant exposure to either secondhand smoke or to some other environmental agents that can induce COPD. Other factors such as smoking cigars, water pipes, e-cigarettes, and cannabis. And quitting smoking is perhaps the single most effective way to prevent and slow down the progression of this disease. The environmental risk factors sometimes are easily overlooked, things like indoor air pollution, and some of which I've already described, occupational exposure to irritants and chemicals, many of them, particularly in areas where there is lots of mining. It's important to ask these questions. And outdoor air pollution. I don't think there's ever been a time where I have seen more papers published around the impact of air pollution on respiratory health than in the last 10 years. So that's an important thing to consider. And one of the things that many of us often will do is remind our patients with COPD, particularly during the hot summer months where there's lots of smog, is to pay attention to something called the Air Quality Health Index and to avoid exposure when that index is high. Once we've got a diagnosis, I think the task of managing COPD in many ways is quite straightforward. We want to get their symptoms controlled day to day. We want to make them less short of breath. And we want to also manage them with a view to reduce their risk of having events such as exacerbations. And one important way to do that is not only to treat them with medications that we know work well, but to also look at non-pharmacologic strategies such as getting them to quit smoking and minimize their exposure to anything that is contributing to their symptoms and to their disease process. In addition to lung function, when we assess our patients, many of these patients have comorbid conditions. And so it's important to assess risk factors that may or may not be playing into their condition. What is their symptom burden? Because that will be relevant in terms of predicting things like life expectancy. And I'll talk about some of these other items that are listed here, like such as MRC and the COPD assessment test a bit later. It's important, especially now, given some of the data that I'm going to share with you, to determine whether patients have asthma-like features, because one of the challenges and realities in primary care is that there is a lot of overlap between asthma and COPD when it comes to how patients present. And sometimes it's difficult to make that distinction. And if you're in doubt and you suspect asthma, then that will impact on the selection of medication and other strategies that you choose. It's important to know a little bit about the frequency and severity of exacerbations, because we know that people who exacerbate more frequently tend to do less well for a number of reasons. There are also indexes that allow us to predict the risk of death, their age, the level of dyspnea, the level of airway obstruction, just to name a couple. And then there's the importance of current medical treatments that are available. And I'll get into some of the details around some of these treatments a little later on. You know, comorbidities, it really isn't new to any of you. I think if you've been in practice for any amount of time, you'll know that patients with COPD come with a lot of comorbidities. And many of you, I'm certain, are aware that most people with COPD die from cardiovascular disease, cancer, and other comorbidities than from respiratory disease. And I think if we're going to make a difference in reducing mortality in COPD, we really have to address the comorbidities. And I think I say that in large part because many of these patients will have heart failure, they'll have well-established coronary artery disease, they'll have other conditions that will be competing for your time and attention when they're coming in and complaining about breathlessness. And on the right-hand side, there's some data from a landmark study called the TORCH study that breaks down causes of death based on disease category. This slide looks a little bit confusing, but I'll simplify it by simply saying that the biggest challenge that we face as family physicians is that by the time patients present to us, typically they are not terribly symptomatic per se, and we often have to probe them to elicit any kind of symptom burden that we consider to be significant. And by that time, their lung function is already down quite dramatically. So most patients typically, depending on the literature that you're looking at, will present for the first time and often relatively asymptomatic with an FEV1 50% of predicted or less. So there is a disconnect between symptoms and lung function. And part of that is driven by the fact that patients will try to minimize their symptoms by doing less. And they adapt to their disease by doing less. And by doing that, they will often present later and with a more impaired lung function. Earlier on, I talked about some tests that we can use to assess COPD control. And this is the COPD assessment test, which is one of a number of tools that are out there. It's an interesting test. It's pretty easy to administer. There are 8 items that I won't go through in any detail, but simply to say patients score from 0 to 5. A score of 40 is not good. A score of 10 or greater is considered to be relevant in terms of having an impact on the patient's quality of life on a day-to-day basis. If we go to another valuable measurement called the Modified Medical Research Council Dysmea scale, we see here that it goes from a grade of 0 to 4. 0 means they only get breathless with strenuous exercise, which is what most of us would experience. And a grade of 4 is when they're too breathless to leave the house, or even breathless when they're trying to get their clothes on, such as bending down even to tie their shoelaces. Sometimes that will cause them to be short of breath. And everything in between is typically where many of our patients will fall in, anywhere from 1 to 3. So those two tools can be very important. They can be adopted to many EMRs, and they're fairly quickly completed by patients. I think overall, if we sort of look at COPD management from a global perspective, we want to relieve their symptoms day to day. We want to minimize their exposure to risk factors and prevent them from declining in terms of lung function. We will try and keep them at a place where they're able to exercise without too much difficulty. Minimizing exposure to risk factors and other things that contribute to disease progression will also act to reduce the risk of exacerbation. And if and when they do occur, it's important to recognize an exacerbation and to treat it quickly. It's just as important to prevent and treat comorbidities. And finally, as I said earlier on, there are very few things that will affect the natural history of COPD, and one of them is smoking cessation. And if you can sort of look at this whole sort of global piece, you can see that what we're trying to do is to improve health status in general. And in a perfect world, we'd also want to reduce mortality. This is a curve that many of you have seen before, and it relates to what happens if we are able to get people to quit smoking. If you never smoked, your lung function is going to drop off simply because of aging. If you do smoke, you see that this red line here, the drop off is much, much steeper. But if you quit smoking, you don't regain what you've lost, but you lose it at a slower rate compared to continuing to smoke. So quitting smoking at any time is a good thing. And so it's important to ask patients and advise them about what happens if they smoke, determine whether they're ready or willing to quit. If they are, to assist them. And if they're at that stage, then it's equally important to arrange follow-up to sustain someone who is able either to cut back or to have quit smoking. I've had the pleasure of being part of the group who developed recent Canadian guidelines on the management of COPD, and I'm going to share some of this information with you. And I think most of us, and I think most of you would agree that early diagnosis, not only in COPD, but in any condition that we manage in primary care, we are in an ideal position to diagnose almost anything early. And we can do that with spirometry, simple spirometry for COPD. We need to work at preventing and treating exacerbations early. And one of the things that certainly I'm guilty of is, not, recognizing the best time or any time to talk about end of life, because some of our patients who progress to a level of impairment where they're basically housebound, when that happens, many of these patients are suffering, their caregivers are suffering, and they're often suffering in silence. So I encourage you, if you notice that, to bring the family in, because they will often not say anything because they don't want to let the patient feel that they're a burden. If they're dyspneic, it's important to determine the severity. If they have symptoms, again, to determine the magnitude of those symptoms. If they've got lung function impairment, then the goal becomes to prevent them from getting more severe, getting them to quit smoking. There's very good evidence to show that self-management education and smoking cessation, including things like exercise and active lifestyles, and some other things that are listed there, they're all sort of foundational pieces when it comes to managing COPD. Once patients are symptomatic, they need to be on some therapy, and bronchodilator therapy is sort of the cornerstone of treatment. And many of our patients will end up on long-acting inhaled therapies, which I'll talk about. Pulmonary rehab, which has been shown to be very beneficial, and there's more and more evidence coming out suggesting that perhaps there may even be mortality benefits. Oral therapies that are available, I'll get into those a little bit later. And there will be some patients who will benefit in terms of longevity if they're hypoxic with the use of long-term oxygen. And finally, lung transplantation is certainly an option for many patients. We don't have lung volume reduction surgery on here, but it's something that you should consider because it's an option that for many patients means not needing lifelong immunosuppressive therapies. And so if these patients will qualify based on where their disease is in their airway, in their lungs, it may make them candidates for a more of a easier to tolerate procedure that has less implications with respects to long-term outcomes. I can remember a patient of mine who didn't qualify for lung volume reduction surgery, but was offered lung transplantation, but declined it because every time he went on prednisone, he became very aggressive and felt that wasn't fair to his wife, who always was affected by his behaviors. If we look at the COPD pharmacotherapeutic guidelines in a bit more detail, what we see is we tend to look at things like the CAT score and the Modified Medical Research Council score to determine how COPD is affecting patients on a day-to-day basis. Then we categorize them based on their risk of an exacerbation. If they're low risk, these are patients who typically have one or less moderate exacerbation in the last year. And these are patients requiring an antibiotic or oral steroids and have had no hospitalizations or admissions or visits to the emergency room during that 12-month period. If you go to the right and look at high risk, these are sicker patients. They have more frequent exacerbations over a period of a year, either 2 or more, or one severe, which includes hospitalization in the last year. So it's important to determine the exacerbation phenotype of patients because they're very good predictors of future events. FEV1 by itself is a poor predictor of exacerbations and mortality. And the best predictor of an exacerbation is a history of having had a previous acute exacerbation. So those two items, I think, are important and establishing an exacerbation phenotype. And I encourage you as well to have a place in your medical records, whether they're paper or EMR, somewhere where you can quickly look to see whether your patient is an exacerbator or not. This is looking at the pharmacotherapy recommendations in a bit more detail. If you have a CAT score less than 10 and an MRC of about 1, you could probably get by with a short-acting bronchodilator, PRN, or a long-acting muscarinic antagonist or a long-acting beta-2 agonist. Once you become more symptomatic, if you're low risk in terms of exacerbation activity, LABA, LAMA, LABA or LAMA is an option. Once patients become symptomatic to the point where their activities of daily living are affected in a meaningful way, it's probably not a bad idea to go to a LABA, LAMA. There's no question that the combination is more effective than the mono components, and that's well established. Then there's also evidence to suggest that if patients remain symptomatic and you feel there is room for improvement, but they're still in that sort of low exacerbation phenotype, then adding an inhaled steroid is also an option. I think where things change quite significantly is when you get into the high-risk patient who has frequent exacerbations. There, you know, based on data that we have, that both LABA, LAMA and ICS LABA will reduce exacerbations. I'm going to cover this issue in a bit more detail moving forward. Again, if patients continue to exacerbate on the therapy I've just highlighted, then adding in an ICS or going to triple therapy is an option. And then there are also oral therapies that I will talk about, things like ramfumilast and prophylactic azithromycin. Some of the things that I'm sure you've heard about a lot over the last few years is that there's really no role for inhaled corticosteroids as monotherapy, and really no role for oral corticosteroids as maintenance therapy. Now, one of the most important and very interesting clinical trials in the last 10 years or so was the FLAME study. And it was the first study to compare ICS LABA to LABA LAMA. And in this case, it was indacaterol and glycopyrronium versus salmeterol and fluticasone. And the interesting thing about this study was that it took patients who had moderate airflow obstruction and at least moderate airflow obstruction or more, and no more than one exacerbation in the previous year. So most patients had one or less exacerbation. And that sort of classifies them into this category of patient that we are probably most likely to see on a day-to-day basis in primary care. And what they found, and the other thing I should note was that this study took great pains to exclude patients with any history of asthma. For obvious reasons, because we don't want to deprive patients with asthma from inhaled steroids in the real world. And what they found was that the LABA-LAMA combination was significantly more effective than the ICS-LABA combination. And this was independent of blood eosinophil counts that I'll come back to a bit later on. So this was the first study to show that patients who have a low exacerbation burden are likely to do better with LABA-LAMA therapy compared to ICS-LABA. And that's why we see this listed in the guidelines, this approach listed in the guidelines in the way that it is. Now, many of you, I would be surprised if you haven't heard a lot of talk and interest around the issue of reduction in all-cause mortality in COPD based on a number of pivotal trials that have been done over the last 5 or so years. This is data from the IMPACT study. And many of these new trials were interesting in the sense that they not only address the issue of how effective are inhaled steroids in COPD management, but they also took the strategy of selecting patient populations that would be comparable to what we see in the real world and would represent the kinds of challenges that we face as clinicians when it comes to making the distinction between asthma and COPD. And so these populations were based, these patients were selected on the basis that in the real world, there's going to be patients who have asthma, and there's going to be patients who have pure COPD, and there's going to be patients who have asthma and COPD overlap. And the question then was, is triple therapy more effective than dual therapy? And I'm not going to go through all the details of these studies because in some cases it's quite extensive, but I do want to focus in general. This is looking at mortality data, but I could easily say the same thing when I make these comparisons for mortality. I could make the same comparisons for exacerbations. So here what we see is that the triple therapy involving fluticasone furoate, umaclidinium, and vilanterol, anything on the left of this line favors this triple therapy. Anything on the right favors umaclidinium or vilanterol, which is the LABA-LAMA version. And so it's interesting. It doesn't matter whether you were on treatment, whether you were off treatment, or whether you included off treatment plus additional data that you obtain on follow-up. Triple therapy in the IMPACT study was superior in terms of not only exacerbations, which I don't show here, but also with respects to mortality. And so this has raised some really interesting points of discussion for us because, as you know, the IMPACT study was not a study powered for mortality. But it's interesting when you select these kinds of patients, it kind of prompts us to think that perhaps in the real world, this strategy may be an option to consider. And many of us are saying that it would be wonderful if we could now replicate this kind of study in a much larger population in a prospective way, because it certainly creates a lot of interesting discussion and hints really for the first time on whether this strategy has an impact on mortality. Sort of a similar message if we look at another study, the Ethos study, looking at the combination of budesonide, glycopyrronium, and formoterol. And I'm not going to go through all this busy stuff, and I won't even go through these busy lines because they're quite difficult to see, but I will say that the message is similar. Among a similar patient population, the risk of death over a 52-week period was significantly lower with triple therapy versus the LABA-LAMA arm. And this occurred with the higher dose of triple therapy. And so what we're seeing here, again, this is a study that wasn't a prospective study where mortality was a primary endpoint, but certainly given the kinds of population that was studied, it raises some really interesting questions, not only about how we might manage patients, but about future studies that we may want to do when it comes to this important issue around triple therapy. Now, for me, one of the most interesting studies, and I think for others as well, is a study referred to as the Chrono Study. And this was a study asking the question, in patients who are not high risk for exacerbations, is there a benefit of adding, is triple therapy more effective than dual therapy? And this study just highlights the sort of the demographics of these patients. But the real point I'd like to highlight was that most of these patients, 3/4 of these patients, did not have an exacerbation in the previous year. And what they found was very similar to the previous studies in that triple therapy was more effective than LABA/LAMA therapy. And again, these are patients for whom asthma, any history of asthma or a past history of asthma was not excluded. And again, it's suggested that these types of populations are the kinds of populations that you and I will encounter in the real world. And so when we look at the Canadian guidelines, if you remember that arm sort of in the middle, where we have that low exacerbation category, where you escalate from LABA/LAMA and you escalate to triple, this is really one of the few studies that fills in that gap, because that a piece of information that I shared with you was really based on retrospective data. This is one of the first and perhaps maybe the only study to date that addresses that issue from a prospective data perspective. Now, here's a little bit of interesting information about death and blood eosinophil counts, the treatment that you're receiving. And what we see here is if you're getting triple therapy, which contains an inhaled steroid, regardless of your blood eosinophil count, and remember, many of us believe that once you start to get to levels of about 400 or 450 and above, many would say that, you know, you can't confirm a diagnosis of asthma, but it wouldn't be unusual for there to be sort of a traditional asthma component in patients with very high blood eosinophil counts. So as patients seem to be stable or drop in terms of mortality, if they're on triple, regardless of blood eosinophil counts, once you take the ICS out of it, what you see is that mortality rises. And I think many people think that, or remind us from these studies, and even in guidelines, is that if you suspect an asthma component in a patient, then there's no question that adding an inhaled steroid is the option of choice. And also, there's no rule that says that patients who start life off with asthma who go on to smoke regularly. And one of the things that's always surprised me over the years when I look at different databases is the prevalence of smoking seems to be slightly higher among asthmatic populations than it is in the general population. I've never quite understood that. So you can go on to develop chronic obstructive pulmonary disease if you start life off with asthma. And if that's the case, then what it tells us that these patients typically are sicker than if they had pure COPD without the asthma component. All the more reason to make certain that we treat them appropriately. And so one of the questions that many of us have been sort of digesting over many years now, based on at least one big study showing that you can effectively withdraw inhaled corticosteroids in patients with moderate to severe disease without increasing their risk of exacerbation. But there's a way to do it, and it doesn't really cost anything to the patient with respects to exacerbation risk. There is a bit of a drop in their lung function. So in patients that you think may be candidates for this, you should try weaning them off. And there's other circumstances where you may consider stopping the inhaled steroid when the original indication for starting is uncertain. And if there's no clinical asthmatic feature, it's something to consider. When the side effects are troublesome, and I've listed some of them there, and if you think that there's no symptomatic benefit after a trial of ICS, it may be a reasonable thing to do. And if their blood eosinophil counts are low, again, some of these points I've spoken to before, and they may come into play when you're making your decisions. So what we see here is that in COPD, we have a strategy to both escalate therapy when it comes to inhaled steroids and de-escalate therapy when it comes to inhaled steroids. And I think you can do that effectively day to day because most of you in primary care will be able to see these patients regularly, and you can adjust the treatment based on their response. And I don't have to tell any of you what the long-term side effects of inhaled corticosteroids are, particularly among women with respects to bone health. Some of the other medications that I alluded to earlier on include the theophylline. Most of us probably don't use these anymore. I haven't prescribed this medication for, my God, many years now. Oral corticosteroids are useful when it comes to managing exacerbations. Ramfumilast, which you're all familiar with, is shown to be effective in patients who have features of chronic bronchitis and who have a history of exacerbations. There is an indication for azithromycin, but there are risks with respects to ototoxicity and resistance. And mucolytics like N-acetylcysteine are listed because sometimes we really are desperate to help patients and don't have much to offer. So it's also listed there. And I think, before you escalate pharmacotherapy, we always should remind ourselves that the treatment decision should match with the symptom burden and the risk of exacerbations. If the burden and the risk is low, that probably is an indication that you may not need to escalate. And again, as I've said earlier on, it's important to assess a number of issues such as comorbidities. What is the phenotype of that patient with respects to exacerbations? Are patients compliant with therapy? We love to think that our patients always take their medication how we advise them to do it, but that's not often the case. Inhaler technique, I'm sure you've heard a ton about that. And sometimes the inhaler device that people choose will affect how they do, and it should be tailored. And I've listed a bunch of things, such as their ability to use at their age, single versus multiple devices. Can they afford the medication? Things to note. A little bit about acute exacerbations of COPD, and I'm going to go through this quickly because you are familiar with it. And that's basically when someone is coming in saying they're feeling worse and they need more therapy. It doesn't make them feel very good. And it does have a significant impact on the likelihood that their lung function will decline at an accelerated rate. Hospitalizations for COPD is associated with a poor prognosis and an increased risk of death. And what's interesting is exacerbations related to COPD are what myocardial infarctions are to coronary artery disease. An exacerbation among COPD patients, it really is not a trivial event. And I think sometimes many of us, we may lose sight of it. I certainly, once I started seeing data around this issue, I was very surprised about how much morbidity was associated with acute exacerbations. So please keep that in mind when you're thinking about the importance of reducing the risk of exacerbations. And again, COPD really is not a trivial disease in primary care and the community as a whole. It's the #1 reason for hospital admissions in Canada. And you've got some major players here as well as coronary artery disease, asthma, heart failure, and diabetes. And there's a checklist that we've included here for you in terms of prevention of exacerbations. And these revolve around things that most of you do on a routine basis, optimizing bronchodilator therapy, get them to stop smoking, vaccinate them fully. The importance of self-management really can't be overemphasized, including the use of a written action plan, using antibiotics and oral corticosteroids when indicated. Dual or triple therapy have been shown to be effective in reducing exacerbations and getting them to pulmonary rehab sooner than later, and considering some of those other oral agents that I discussed earlier on. Make sure when they're at home, particularly now during COVID, that the patients have a plan, that they have access to their inhaled bronchodilators, that they have their action plan accessible with respects to corticosteroids and antibiotics, and then go through a list of things that they should be sure of if they're needing oxygen therapy, non-invasive ventilation, antibiotics and steroids. All of these items here are really sort of part of what patients will often include as part of their action plan and their overall management plan. Some of the key messages: COPD is treatable, it's preventable, and we need to diagnose it earlier. Most of the things here that I've listed, I've already highlighted, so I won't go through them again, but just a quick reminder that there is it's important to balance pharmacologic and non-pharmacologic therapies, to get the family involved around education on how to manage COPD, and to provide that family with the most support possible, and assess them regularly to make sure that they're not declining. And if they are declining, to pick up that decline as soon as you can. So let's talk about Mary for a minute. And Mary is 52 years old. She's an office worker. She lives with her husband and 2 grown children. She quit smoking 10 years ago after a 20-pack year history. She reports 2 colds in the past year and chronic cough. Her father was diagnosed with COPD when he was in his 60s. I'm always amazed, you know, whenever I do these talks and I see a picture of a COPD patient, they always look different than the picture in the slide. So in terms of comorbidities, Mary has hypertension. She had an MI 4 years ago, no history of asthma or atopy. On physical exam, there's decreased breath sounds bilaterally. The chest x-ray was normal. She had reduced lung function in terms of FEV1 FVC ratio that was at 0.065, which was below the lower limit of normal, and her FEV1 was 75% of predicted. Are there other possible causes of Mary's breathlessness? Please enter the answers in your chat box, and we will get to them just as we finish the case. She indicates that I feel okay most of the time. I've noticed that I do get short of breath when I am in a rush and during my evening walk when I'm going up a hill. Mary's symptoms are mild. She scores 8 on the CAT and falls under the modified MRC as a grade 1. So think about where that would put her based on that schematic that I shared with you earlier on. So let's take a polling question here. What will you consider before making treatment decisions with Mary? And the options are listed there. FEV1 reversibility, 2% post-bronchodilator. B, current symptoms. C, history of exacerbations. D, lung function impairment. And E, B, and C. Great. Perfect. That's awesome. We'll get back to this later on, guys, but that was great. What is your initial approach to pharmacologic therapy? Please enter that answer into your chat box. If we go back to the Canadian guidelines, what we see is that Mary has a CAT score less than 10, and an MRC score of 1. So she would fall under the mild category here. And so when we get to the end of it, we'll look at the chat and see what you thought. Mary decides on no therapy at the present time, which is not unusual for many patients at this stage of their illness. Which non-pharmacologic interventions would you recommend? Select all that apply. A, self-management education, including inhaler instruction, physical activity, pulmonary rehab, other interventions. Neat. And yeah, you know what? Most of these items are things that we've talked about and have all been shown to benefit patients quite a bit. So Mary returns a year later, and she says that she has increasing shortness of breath with her regular activities. She now rates herself as a 2 on the MRC scale and a 12 on the CAT. She reports increasing cough, but has not received any treatment with antibiotics or prednisone. She was seen by a cardiologist 3 months ago, and her symptoms were not thought to be related to worsening heart disease. Which of the following therapies might you recommend for Mary? A LAMA, B, a LABA, C, a combination of LABA-LAMA, D, an ICS-LAMA combination, or triple therapy with LABA-LAMA ICS. That A should be an S. Excellent. And certainly we can talk about that because she certainly would fit the LABA-LAMA choice quite well based on what we've talked about. So now I'm just going to end the formal talk and just share some of the resources that are available to you. And many of these sort of, we have to sort of thank our colleagues at the Lung Health Foundation for doing a tremendous amount of work on developing so many different patient aids, physician aids around education and management. And this is really just an outline of the care circle for these patients and supporting their journey over time. And it sort of touches on a number of the things that I've already talked about, engaging the patient, the family, and the healthcare provider. Many of you may be aware of quality standards for COPD that are available out there that in many ways echo and reflect what's in the Canadian COPD management guidelines. This is something that I had the pleasure of working with on the management of COPD during COVID-19. And one of the things we really struggled with was developing a tool that you not only can use during COVID, but you could also use during the time when COVID is no longer a major part of our conversation on a day-to-day basis. So this is available and it's pretty simple to read. I'm a little biased, but we had a number of really amazing individuals who worked on this, who were experts in education, and we're hoping that it'll be helpful to some of you. There's some great e-learning opportunities that have been developed by the Lung Health Foundation in conjunction with our colleagues in respiratory medicine. And one of them here is COPD in primary care. There's a couple of modules. I encourage you to look at them. They're user-friendly, they're very informative and very comprehensive. And at this point, I'm going to thank you very much for your attention, and we're happy to entertain any questions or comments that you might have. Thank you.
Thank you, Dr. Durzo. A few questions have come in. And also people did have an opportunity when they registered to list any questions. So there's a couple from that as well. So those were pre-talk, but I'll start with the ones that are coming up here during the session. So again, there's a couple. So the first one is around the role of Prevnar over Pneumovax 23. Any role that you see?
I think, most people will say that Prevnar may provide, it depends, if we're talking with respects to COPD, there is data to suggest that Prevnar may elicit a greater immune response. And most of us in day-to-day care are giving patients both of those.
Fair enough. Yeah, no, that's great to know. And I'm going to just jump ahead a little bit. I'll come back to the specific question that is around a very specific occupation, but I just wanted to touch on spirometry because you did mention how important spirometry was for diagnosis. Someone has asked, when would you repeat spirometry?
That's a great question. And if I was just going to speak around that issue based on the evidence that exists, the US task force suggests that in reality, based on the data that's available, we could probably get by doing spirometry with respects to establishing the diagnosis. And there's no data to suggest doing it more frequently affects the management and the outcome of patients. Having said that, many of us will often use spirometry, particularly after patients are recovering from an exacerbation, because we like to and hope to see that their lung function they've regained their baseline level of lung function, because some of us would find that important to know. Because many of these patients have other comorbidities, and we're always trying to explain their level of shortness of breath based on their lung impairment, or if they've got some congestive heart failure component playing in. So I will do it more frequently, particularly after they've had an exacerbation and they've recovered, and I'm curious to see whether they've regained their baseline level of function.
Okay, great. Thanks for that answer. I'm going to go back to this question, very specific around a specific occupation. So this is around the challenges of diagnosing someone who may not be showing symptoms right away, but are in a high-risk occupation. Do you recommend chest X-ray or spirometry routinely for screening in light of maybe occupational or environmental risk factors?
That's a great question. And I think, one of the probably the best way to address that is that if you think a patient has a risk exposure, then we tend to think that their pre-test likelihood is going to be high. And so that increases the value of doing spirometry, potentially, not always, but potentially. And there are, for example, conditions where farmers who are chicken farmers, for example, who will get exposure and they won't be symptomatic, but when you do spirometry on some of these patients, you may see some early changes. And so I think spirometry, will allow you, if you have the suspicion, because I think it really boils down to what your suspicion is. If you're concerned and you think the risk is real and significant, the worst that can happen is if you do spirometry and it's normal, then that's great. You have everything you need to know. If you do spirometry in the same kind of individual, but who is a bit more symptomatic, but you can't explain that symptom level of symptomology based on spirometry, that's also important because there may be other factors contributing to what they're how they're feeling. So I think it becomes sort of a choice based on your risk assessment, and if you think it's high, no one would ever hold you back. Chest X-rays, unfortunately, are low yield for COPD. They're low yield for things like lung cancer. They're low yield for many things with respects to the lung parenchyma. And so I don't usually go to them. I always remember one of the first things we learned in medical school was, how will your care of this patient change if you do this test? And if you don't think it will change, then you may not want to do it.
Very good. Well, that's very helpful. So I do want to say thank you to the people putting questions in the Q&A box. There's still questions coming in, so I'm going to keep going. So the next person says, thank you for the helpful review. Would you mind also covering a bit more about any key considerations for those patients with COPD and asthma?
That's a great question. And I think as family docs, we really have a tough job because there's something called adult onset asthma, and there is COPD. And then you have the traditional asthma patient who starts off with asthma as in childhood and goes on to smoke. And so what I would suggest is one of the first considerations that I've always found helpful is, do I feel comfortable committing to what I think is going on with this patient, i.e., do I think it's purely asthma? Do I think it's purely COPD? Or do I feel there's elements of both? And the reality is that adult onset asthma will happen, and it will happen in people who, remember earlier on I said that only about 20 to 25% of people who smoke cigarettes will go on to develop COPD. So the minority of people who smoke will develop COPD. But among those, there will also be those people who smoke, who don't develop COPD, but who develop adult onset asthma. And so then it becomes really important to try and tease that out based on the history, because the history will give you some insight in terms of what you're going to do in terms of management. So the advice I think I would share with you is, keep that distinction in mind. Most of the time, you should be able to use the spirometry that you have, plus the history that you've obtained, to come to a decision on what you think you're dealing with, because there will be many patients who will have spirometric features that are compatible with both asthma and COPD. And in those cases, you're really going to have to rely on the history and other risk factors to make a treatment decision. If you think a patient has clinical features of asthma and COPD, then there's no question that they should be on a treatment that includes inhaled corticosteroids. If you don't, then you'll do just fine, including a treatment where they'll thrive and do well, not only in terms of lung function, but also exacerbation reduction if they're on dual bronchodilator therapy.
Very good. Thank you so much. So a couple more questions. We have about 3 minutes or so. This sounds, I'm actually going to, oh, so hard to choose, but I'm going to go in order. Thank you for the great talk. I'm glad you mentioned pulmonary rehab as part of patient management for these patients. I'm curious as to how much PR is on the radar of primary care physicians. This is from a physio working in pulmonary rehab.
Yeah.
So like maybe for yourself, you could only really comment for yourself.
Yeah, I've used it a fair bit. And I think my sense is that my colleagues in pulmonary rehab will probably say that it's underutilized, and it is. I think another challenge that we face is access. There was a time, and there still are places, depending on where you live, where it may be difficult to get access to pulmonary rehab. My general sense is that most people feel that it's underutilized, and I think that I'm not sure if it's in most part because it's not on the radar, but I think sometimes patients do such a good job at adapting their lifestyle that it may cause us to underestimate their need for pulmonary rehab. So I think it's a bunch of things, but there's no question that access and not making that referral are important barriers.
No, good to highlight that for sure. It's such an important aspect of overall management. So I'll just quickly move on. When the patients in a moderate to severe category are at a low risk of acute exacerbation, would you mind highlighting how you choose between LAMA and a LABA?
That's a really good question. Thank you for that. And I think one of the things I didn't talk about, and I'm glad you brought that point up, and that is that in the end, we're looking at exacerbation reduction, and there is some evidence to suggest that LAMAs may be a bit more effective than LABAs at reducing exacerbations in general, just because of the class. We're not completely sure why that is, but there's data to suggest that LAMAs may be a bit more effective than LABAs. But I think once you're combining, it really doesn't matter, because then you have that class effect with whichever LAMA you're using. I think the challenge many physicians have, based on how the guidelines evolve, is that most of us in patients with a CAT greater than 10 and an MRC greater than 1 would go right to a LABA-LAMA, as opposed to trying one of the monocomponents and then escalating, simply because the dual therapy is better. It's more effective. The reason it's stated that way in guidelines is because that's how they're studied, and we feel that we have to be politically correct. But most of us in a patient like Mary, after she comes back from a year's absence, would start her on a LABA-LAMA right off the bat.
Yep, that makes sense. Yeah. All right. So the next question is, does bring COVID into the scenario. What are your thoughts on the COVID booster for the COPD population?
That's a great question. And I think that, one of the things that we do know about COVID-19 is that if you have COPD and you get sick, you can get into real trouble. I find this kind of question difficult to answer, because it really is a sort of a moment in time question. If we're just thinking about the Delta variant right now, I would probably say that if I had a COPD patient and we had access to vaccine, I would probably offer it to them, primarily because there are many things we can't know about that patient. You know, what kind of immune response did they mount the first time during the first and second vaccines? We assume that it's a reasonable one, but you really can't know that. But what you do know is that there will be quite a high likelihood that if you do give them a boost, that should bump them up a little bit. And if they've got advanced disease, because many of them will have comorbidities, I would not be uncomfortable giving them that third booster if there was no contraindication to do so.
Very good. Well, I want to be respectful of everyone's time. It is 8:01. There are still questions coming in, but what we'll do is we can save these questions, and then when session 2 comes up, maybe some of these things can come up in session 2, and hopefully we can address people's questions. So we do encourage all of you online. Thank you very much for being here today. And we encourage you to come to session 2. It is taking place on October 19th. We will send out a reminder email just in case you haven't registered for it. If you have already, that's great, but we'll definitely touch base with you after this session about that. Just like to thank our speaker, Dr. Druzo. Thank you so much for a wonderful talk and for just touching on so many important points around management of COPD patients. And again, I welcome everybody to join us again in a couple of weeks, but I will close the session off. An evaluation is available, so please use the scanner there on the screen. You see it now. Just use your phone to scan that QR code, and then you'll get the evaluation sent directly to you. So please fill out the evaluation and send us your feedback. So again, thank you very much, and I'll close things off here, and we'll see you again next time.
Just a quick note to the participants, we'll also send you the evaluation link via email so you can fill it out there also. And one last note, thank you so much to both of you for this presentation, and to the participants, thank you for participating, and everyone have a great rest of your night.